Hey guys, today we are going to talk about intrinsic asthma and the general clinical features about the asthma. So let's start it. So first, if you are going to discuss about the intrinsic asthma, you have to understand like a sympathetic and parasympathetic pathway effect to the lungs. So sympathetic pathway effect to the lungs is gives the bronchodilation with the effect of beta 2 receptor, and bronchial smooth muscles is gonna also affect by the sympathetic nervous system. For parasympathetic nervous system is gonna affect go to through the bronchoconstriction. So due to intrinsic asthma, this bronchoconstriction is gonna happen. So it is autonomic dysfunction due to the hypothalamus, and we can control this by using this drug. It's called apratropium bromide. Is a drug of a choice for for effect on the bronchoconstriction to the bronchodilation. So let's start with the general histology about the bronchi. Bronchi, the lining is ciliated column epithelium, and mucosa has epithelium and basement membrane, and some mucosa has bronchial glands and blood vessels. And muscularis contain smooth muscles, and adventitia contain connective tissue and blood vessels. So now we can talk about just the asthma clinical features. So asthma for intrinsic, you can see a lot of mucus plug. So the patient will have a lot of mucus in his lungs. So for the labs, we can see like WBCs increase eosinophils due to interleukin 5. I already discussed this all pathway in my previous video. You can see and check it out. And you can see like a diamond shaped proteins there. And for the sputum culture test, you say carrot cord, leaden crystals, and also you can see Crushman spirals there. So this is the key points you have to understand for the sputum test to see. If you see this kind of a thing, this means is a asthma. And degenerative epithelium and hypertrophic muscles, and also you can see like a bronchial gland get hypertrophy. So all features of asthma. For the clinical features, the onset you can see like a chest tightness, dyspnea, cough and sputum, wheezing, and variation of the symptoms depend on the patient. Sometimes nighttime patient has a lot of sputums, and if there is a white sputum, it means it's a non-infected. And allergic rhinitis in the 70% of the patient have sneezing, runny nose, nasal dripping. So you can see there. For the physical examination, you see trachea, tachycardia, chest tightness, and resonant sound. But for the key point you have to understand here, the resonant sound you should listen in from the both lungs. Bronchi, I wrote here, bronchi should be listened from the both side of the lung because it's the asthma. It's not bronchiectasis, it's not pneumonia, it's not pneumothorax. So you have to see from the both lungs. For the lab, for x-ray, x-ray you won't do it because you cannot see asthma in x-ray. You have to go with the CBC, see the high eosinophils and high antibodies E, or you can go with the arterial blood gases test. And here you will see the patient would have like a hypoxia and hypercapnia, but mostly you see hypoxia, and carbon dioxide levels should be normal in this asthma condition, and this leads to type 1 respiratory failure. So here you see in the type 1 respiratory failure, oxygen is going to be decreased, but carbon dioxide is going to be normal. For all pulmonary disease leads to type 1 respiratory failure except COPD, because COPD is obstructive disease, so you're gonna see hypercapnia. And one more test you can see here, it's called pulmonary function test, PFTs, and it's a really important test. You have to do it, and it's really cheap, so it's easy to do it. So first we see FEV1. What is that? Forced expirated volume per second, and FVC, forced vital capacity. So if the patient has less than 80%, so it means it's an obstructive disease. If the patient has more than restrictive 80% means it's a restrictive disease. So for the test, what we have to do, we gave the patient to the salbutamol nebulizer, like a more than 15 mm. So if it's reversible, if the patient has more than 15% FEV1, it means it's asthma. So it's not obstructive disease because it's going inside and it's giving the bronchodilator effect. But in the COPD, it's irreversible, and FEV1 gonna be the same because it's obstructive, not restrictive disease. So that's it for today, guys. I hope you will like it.